Hello everybody, today we have an interview with one of the famous surgeons. We will discuss abdominal compartment syndrome. Hello doctor and welcome to our studio and our YouTube channel #1 doctor.
Hello. Thanks for you and all your channel subscribers.
Doctor, what is the abdominal compartment syndrome?
Abdominal compartment syndrome was recognized clinically in the 19th century when Mary and Burt observed its association with declines in respiratory function. In the early 20th century, Emerson's animal experiments demonstrated mortality associated with abdominal compartment syndrome. Initially, cardiorespiratory compromise was thought to be the cause. However, renal failure was hypothesized by Wendt and was later studied by Thorington and Schmidt. More recently, Cron and Ibati developed a simple method of accurately measuring intra-abdominal pressure. This has led to a better understanding of the relationship between ear and abdominal compartment syndrome. The World Society of the Abdominal Compartment Syndrome had published the following definitions and recommendation. Intra-abdominal pressure (IP) is approximately 5 to 7 mm Hg in critically ill adults. Intra-abdominal hypertension is defined by a sustained or repeated pathological elevation in IP of greater than or equal to 12 mm Hg. ACS is defined as a sustained IP greater than 20 mm Hg associated with organ dysfunction or failure. IH is graded as follows: Grade I, IP 12 to 15 mm Hg. Grade II, IP 16 to 20 mm Hg. Grade III, IP 21 to 25 mm Hg. Grade IV, IP greater than 25 mm Hg. Recommend measuring intra-abdominal pressure when any known risk factor for IH or ACS is present in critically ill or injured patients. Recommend that studies of IH or ACS adopt the transbladder technique as a standard IP measurement technique. Recommend decompressive laparotomy to decrease IP in cases of overt ACS. Suggest brief trials of neuromuscular blockade as temporizing measure in treatment of IH.
Doctor, what about types of abdominal compartment syndrome?
3 categories. As the diagnosis of abdominal compartment syndrome became easier to establish, it was observed to occur as a consequence of a variety of primary clinical events. Abdominal compartment syndrome can be divided into the following 3 categories. Primary or acute abdominal compartment syndrome occurs when intra-abdominal pathology is directly and proximally responsible for the compartment syndrome. Secondary abdominal compartment syndrome occurs when no visible intra-abdominal injury is present, but injuries outside the abdomen cause fluid accumulation. Chronic abdominal compartment syndrome occurs in the presence of cirrhosis and ascites or related disease states, often in the later stages of the disease.
Doctor, what about pathophysiology of abdominal compartment syndrome?
Organ dysfunction with abdominal compartment syndrome is a product of the effects of IH on multiple organ systems. Abdominal compartment syndrome follows a destructive pathway similar to compartment syndrome of the extremity. Problems begin at the organ level with direct compression. Hollow systems such as the intestinal tract and portal caval system collapse under high pressure. Immediate effects such as thrombosis or bowel wall edema are followed by translocation of bacterial products, leading to additional fluid accumulation, which further increases intra-abdominal pressure. At the cellular level, oxygen delivery is impaired, leading to ischemia and anaerobic metabolism. Vasoactive substances such as histamine and serotonin increase endothelial permeability. Further capillary leakage impairs red cell transport, and ischemia worsens. Simon et al. Demonstrated a significantly lowered threshold for injury from IH in pigs after hemorrhage and fluid resuscitation. Oxygen delivery may play an important role. Although the abdominal cavity, that is, the peritoneal and, to a lesser extent, retroperitoneal cavities, is much more distensible than an extremity, it reaches an endpoint at which the pressure rises dramatically. This is less apparent in chronic cases, because the fascia and skin slowly stretch and thus tolerate greater fluid accumulation. As pressure rises, abdominal compartment syndrome impairs not only visceral organs, but also the cardiovascular and the pulmonary systems. It may also cause a decrease in cerebral perfusion pressure. Therefore, abdominal compartment syndrome should be recognized as a possible cause of decompensation in any critically injured patient.
Doctor, what about the etiology of abdominal compartment syndrome?
Primary or acute abdominal compartment syndrome include penetrating trauma, intraperitoneal hemorrhage, pancreatitis, external compressing forces, such as debris from a motor vehicle collision or after a large structure explosion, pelvic fracture, rupture of abdominal aortic aneurysm, perforated peptic ulcer. In one review and meta-analysis of studies of patients who developed ACS after repair of ruptured abdominal aortic aneurysms, mortality was found to be 47%. Treatment included open decompression in 86 patients, percutaneous drainage in 18, catheter only in 5, combined with tissue plasmagen activator infusion in 13, and conservative measures in 5. Secondary abdominal compartment syndrome may occur in patients without an intra-abdominal injury, when fluid accumulates in volumes sufficient to cause IH. Causes include the following: large volume resuscitation. The literature shows significantly increased risk with infusions greater than 3 liters. Large areas of full thickness burns. Hobson et al. Demonstrated abdominal compartment syndrome within 24 hours in burn patients who had received an average of 237 milliliters/kilograms over a 12-hour period. Penetrating or blunt trauma without identifiable injury. Postoperative packing and primary facile closure, which increases incidence. Sepsis. A retrospective study reported on risk factors directly associated with mortality in patients with both intra-abdominal hypertension and ACS. Polite transfusion was a strong predictor of mortality, along with the reported history of diabetes and the total amount of blood products used. Secondary ACS in patients with lower extremity vascular injuries from penetrating injury or blunt trauma was associated with a 60% mortality in one study. Causes of chronic abdominal compartment syndrome include peritoneal dialysis, morbid obesity, cirrhosis, Meigs syndrome, intra-abdominal mass.
Doctor, what about the epidemiology of abdominal compartment syndrome?
According to recent literature, the frequency of abdominal compartment syndrome in trauma ICU admissions is anywhere from 5 to 15% and 1% of general trauma admissions. Much of the recent literature on abdominal compartment syndrome has originated from outside the United States, where frequency and morbidity appear to be the same. Abdominal compartment syndrome has been documented in all age groups. The if that leads to morbidity greater than 25 mm Hg appears to be similar in the pediatric population.
Doctor, what about the prognosis of abdominal compartment syndrome?
If left untreated, abdominal compartment syndrome is almost uniformly fatal. Eddy and colleagues documented a mortality of 68% for patients with documented abdominal compartment syndrome. Most of the population was male, 70%, and most had experienced blunt trauma, 80%. In the subsequent literature, mortality rates have ranged from 25 to 75%. The high mortality in abdominal compartment syndrome, even with treatment, reflects the fact that the condition affects multiple organ systems. Furthermore, abdominal compartment syndrome is often a sequela to severe injuries that independently carry a high morbidity and high mortality. Moore-Brain et al. Demonstrated that by itself, elevation of abdominal pressure correlates with increased mortality before the actual development of abdominal compartment syndrome. In one review and meta-analysis of studies of patients who developed ACS after repair of ruptured abdominal aortic aneurysms, mortality was found to be 47%. Treatment included open decompression in 86 patients, percutaneous drainage in 18, catheter only in 5, combined with tissue plasminogen activator infusion in 13, and conservative measures in 5. A retrospective study reported on risk factors directly associated with mortality in patients with both intra-abdominal hypertension and ACS per light transfusion was a strong predictor of mortality, along with the reported history of diabetes and the total amount of blood products used. A 5-year retrospective study at 3 Level 1 trauma centers in Chicago identified the following prognostic factors in trauma patients with ACS. The 30-day mortality was strongly associated with an initial intra-abdominal pressure greater than 20 mm Hg and moderately associated with blunt injury mechanism. Lactic acid level greater than 5 mol/L on admission was moderately associated with increased blood transfusion requirements and with acute renal failure during hospitalization. Developing ACS within 48 hours of admission was moderately associated with increased length of stay in the ICU, more ventilator days, and longer hospital stay. Initial operative intervention lasting more than 2 hours was moderately associated with risk of developing multi-organ failure. Hemoglobin level less than 10 g/dl on admission, ongoing mechanical ventilation, and ICU stay greater than 7 days were moderately associated with a disposition to long-term support facility. Signs and symptoms can include the following: increase in abdominal girth, difficulty breathing, decreased urine output, syncope, melena, non-steroidal anti-inflammatory drug use, alcohol abuse, nausea and vomiting, history of pancreatitis. Abdominal compartment syndrome may be obscured in patients with critical injuries. Failure to consider abdominal compartment syndrome prevents diagnosis and treatment. Many disease processes can contribute to abdominal compartment syndrome. Consider IH and document intra-abdominal pressures in any of the following patients: intubated patients who have high peak and plateau pressures and are difficult to ventilate, patients who have GI bleeding or pancreatitis and are not responding to intravenous IV fluids, blood products, and pressors. Patients who have severe burns or sepsis with decreasing urine output and are not responding to IV fluids and pressors. Any patient with contradictory Swangen's readings. Regarding physical examination, compartment syndrome in the abdomen is usually suggested by an increased abdominal girth. If this change is acute, the abdomen is tense and tender. Although this may be difficult to recognize in patients with morbid obesity, other patients often have an abdomen clearly out of proportion to their body habitus. This may be easier to visualize with the patient standing or sitting upright. In addition to distended abdomen, other secondary effects of abdominal compartment syndrome are as follows: wheezes, rolls, increased respiratory rate, cyanosis. 1 appearance.
Doctor, what about the complications of abdominal compartment syndrome?
Abdominal compartment syndrome itself can involve almost any organ system. Renal failure. This is not prevented by intraretroviral stents, which suggests direct compression of renal parenchyma and decreased renal perfusion as causes. Respiratory distress and failure. Initial signs of abdominal compartment syndrome include elevated peak airway pressures in intubated patients with decreased tidal volumes. Bowel ischemia. Increased intracranial pressure (ICP). Decompressive laparotomy has been shown to reduce intractable elevated ICP in patients with IH failing cardiac output and refractory shock. Abdominal compartment syndrome factitiously elevates central venous pressure (CVP) and pulmonary capillary wedge pressure in patients who are hypovolemic or euvolemic.
Doctor, what about abdominal compartment syndrome differential diagnosis?
Diagnostic considerations include abdominal trauma, blunt, appendicitis, acute, cholangitis, congestive heart failure and pulmonary edema, dissection, aortic, diverticular disease, foreign bodies, gastrointestinal, mesenteric ischemia, pediatrics, bacteremia and sepsis, urinary obstruction.
Doctor, what about investigations for abdominal compartment syndrome?
The following lab studies may be indicated: comprehensive metabolic panel, complete blood cell count (CBC), amylase and lipase assessment, prothrombin time (pint), activated partial thromboplastin time (PTT) if the patient is heparinized, cardiac marker assays, urinalysis and urine drug screen. Measurement of serum lactate levels. At many institutions, the sample must be kept on ice. Arterial blood gas (ABG). This is a quick way to measure the pH, lactate, and base deficit. Abdominal CT scanning can reveal many subtle findings. Picard et al. Found the following in patients with abdominal compartment syndrome: round belly sign, abdominal distension with an increased ratio of anteroposterior to transverse abdominal diameter ratio greater than 0.80, collapse of the vena cava, bowel wall thickening with enhancement, bilateral inguinal herniation. Plain abdominal radiographic studies are often useless in identifying abdominal compartment syndrome, although they may show evidence of free or bowel obstruction. Abdominal ultrasonography may reveal an aortic aneurysm, particularly with large aneurysms, but bowel gas or obesity makes performing the study difficult.
Doctor, what about intra-abdominal pressure measurement?
Intra-abdominal pressure can be easily monitored by measuring bladder pressure. Measurement of intraluminal bladder pressure consists of instilling about 25 milliliters of saline into the urinary bladder through the Foley catheter. The recommended volume is 25 milliliters, but studies have demonstrated similar measurements using only 10 milliliters. The tubing of the collecting bag is clamped, and needle is inserted into the specimen collecting port of the tubing proximal to the clamp and is attached to a manometer. Bladder pressure, measured in millimeters H2O, is the height at which the level of the saline column stabilizes with the symphysis pubis as the 0 point.
Doctor, what about grading of abdominal compartment syndrome?
The following grading system has become accepted if EA is present: grade I, 10 to 15 centimeters H2O. Grade 2, 15 to 25 centimeters H2O. Grade 3, 25 to 35 centimeters H2O. Grade IV, greater than 35 centimeters H2O. End organ damage has been observed with IOP as low as 10 centimeters H2O, and multiple studies have found damage at values ranging from 20 to 40 centimeters H2O. Disparity exists because abdominal compartment syndrome never occurs as an isolated event. Cheatham et al. Found abdominal perfusion pressure to be a much better predictor of end organ injury than lactate, urine output, or base deficit. The abdominal perfusion pressure is equal to the mean arterial pressure minus the IOP.
Doctor, what about abdominal compartment syndrome treatment and management?
If abdominal compartment syndrome is suspected, the focus of pre-hospital care is to immediately transport the patient to the emergency department. Remove any constricting garments. Do not place anything on the patient's abdomen, for example, external defibrillators, bundles of blankets, oxygen tanks. Avoid overly aggressive fluid resuscitation, especially in extremity injuries. The over-resuscitated patient is much more likely to develop abdominal compartment syndrome, and often the pre-hospital setting is where this begins. 21. In the emergency department, the first priority of the ED physician is to consider the diagnosis in any patient with the appropriate mechanisms of injury or pathology. Abdominal compartment syndrome will be missed unless it is in the differential diagnosis. Therapy should include fluid resuscitation and transfusion if needed, as well as surgical consultation. A comprehensive, evidence-based approach to the management of abdominal compartment syndrome that includes early use of an open abdomen has been shown to reduce mortality. 28. A group in Taiwan has used laparoscopic decompression successfully in blunt abdominal trauma patients who have a NIP of 25-35 cm H2O. The World Society of the Abdominal Compartment Syndrome has noted that correct fluid therapy and perfusional support during resuscitation form the cornerstone of medical management in patients with abdominal hypertension. 30. 2. Pharmacologic therapy is less effective than mechanical drainage. Pressors have a role but may not be equally effective in treating abdominal compartment syndrome. Dobutamine was shown to be superior to dopamine in restoring intestinal mucosal perfusion in a porcine model. 31. Inpatient care in acute abdominal compartment syndrome is directed by critical care physicians and surgeons. If an ICU patient experiences decompensation, abdominal compartment syndrome should be re-examined as a potential cause. IAH may be an ongoing process in any patient with pathology producing intra-abdominal fluid loss. Repeat or continuous IP measurement is indicated. The abdomen should be clear of any heavy objects. Consultations may be indicated with the following: general surgeon, orthopedic surgeon, obstetrician and gynecologist, OB/GYN, vascular surgeon. Multiple reports document the efficacy of paracentesis in burn patients who develop abdominal compartment syndrome. Although not prospectively validated, it appears to be a superior alternative to decompressive laparotomy in this patient population. It may be performed quickly at bedside and avoids potential complications associated with larger incisions. Paracentesis is also extremely useful in patients with chronic abdominal compartment syndrome from large volume assets. Secondary effects of abdominal compartment syndrome occur immediately after evacuation. Many cases of hypertension and even asystole have been observed. Theories to explain these effects include washout of products of anaerobic metabolism, for example, lactic acid, which may be directly tissue toxic, and suddenly decreased systemic vascular resistance, SVR. Volume resuscitation immediately before decompression has been shown to significantly decrease these events. Adding mannitol and sodium carbonate (NaCO3) to the IV fluid bolus may decrease the toxicity of reperfusion syndromes. Outpatient care is directed at the primary etiology of abdominal compartment syndrome. Chronic abdominal compartment syndrome requires lifelong medications and lifestyle changes, which may include the following: diuretics, fluid restriction, weight loss, avoidance of alcohol. Consider transfer of any patient who requires services not available at the current facility. Patients with abdominal compartment syndrome frequently require admission to the ICU. Any patient with documented abdominal compartment syndrome requires an emergent surgical consultation. Surgical services of multiple disciplines may be consulted. If a surgeon is not immediately available, the patient must be transferred. Transfer is indicated for any patient meeting local trauma center guidelines. Preventing abdominal compartment syndrome is much more effective than treating it. The literature is replete with recommendations directed primarily at post-surgical care regarding prevention of abdominal compartment syndrome. Primary facile closure has been prospectively demonstrated to significantly increase the incidence of abdominal compartment syndrome after laparotomy, specifically in patients who have undergone damage control surgery. Various types of surgical mesh are helpful to decrease the incidence of abdominal compartment syndrome. Prevention is also focused on early treatment of ear. Many authors now recommend managing ear before full abdominal compartment syndrome develops. This can only be accomplished by proactive IP measurement and monitoring. Controlled, randomized studies have highlighted the possibility of preventing abdominal compartment syndrome by avoiding pure crystalloid resuscitation in trauma and burn patients. O'Mara et al. Demonstrated a significantly lower IP in burn patients resuscitated with a colloid combination of fresh frozen plasma and lactated Ringer solution versus lactated Ringer solution alone, given by the Parkland formula. 32. At a large Japanese burn center, Oda et al. Demonstrated hypertonic lactated saline could be used in smaller volumes to maintain adequate urine output and significantly reduce the rate of abdominal compartment syndrome and associated morbidity. Hecker et al. Described 5 treatment columns for intra-abdominal hypertension or acute compartment syndrome: intraluminal evacuation, intra-abdominal evacuation. Improvement of abdominal wall compliance if fluid management, improved organ perfusion if conservative therapy fails. Emergency laparotomy is the most effective therapeutic approach to achieve abdominal decompression.
Doctor, what about guidelines?
The World Society of the Abdominal Compartment Syndrome had published the following definitions and recommendations. Intra-abdominal pressure is approximately 5 to 7 mm Hg in critically ill adults. Intra-abdominal hypertension is defined by a sustained or repeated pathological elevation in IAP of greater than or equal to 12 mm Hg. ACS is defined as a sustained IAP greater than 20 mm Hg associated with organ dysfunction or failure. IAH is graded as follows: Grade I, IAP 12 to 15 mm Hg. Grade 2, IAP 16 to 20 mm Hg. Grade 3, IAP 21 to 25 mm Hg. Grade IV, IAP greater than 25 mm Hg. Recommend measuring intra-abdominal pressure when any no-risk factor for IAH or ACS is present in critically ill or injured patients. Recommend that studies of IAH or ACS adopt the transbladder technique as a standard IP measurement technique. Recommend decompressive laparotomy to decrease IP in cases of overt CTH-independent S. Suggest brief trials of neuromuscular blockade as temporizing measure in treatment of IAH. Doctor, what about medications? The goal of pharmacotherapy is to reduce intra-abdominal pressure. Diuretics are used for this purpose. However, pharmacologic therapy is less effective than mechanical drainage. Diuretics decrease plasma volume and edema through diuresis. Furosemide L6. Furosemide increases excretion of water by interfering with the chloride-binding cotransport system, which, in turn, inhibits sodium and chloride reabsorption in the ascending loop of anal and distal renal tubule. The dose must be individualized. Depending on response, administer at increments of 20 to 40 mg no sooner than 6 to 8 hours after previous dose, until desired diuresis occurs. When treating infants, titrate with 1 mg/kg/dose increments until satisfactory effect is achieved. Spironolactone, aldactone. This agent is used for management of edema resulting from excessive aldosterone excretion. It competes with aldosterone for receptor sites in distal renal tubules, increasing water excretion while retaining potassium and hydrogen ions. Amiloride. Amiloride is a pyrase in carbonyl guanidine unrelated chemically to other known antigalliuretic or diuretic agents. It is a potassium-conserving antigalliuretic drug that, compared with thiazide diuretics, possesses weaker diuretic, and antihypertensive activity.
Thanks, Doctor.
Thanks for you and for your subscribers.
Thanks for watching. Hope to see you again in next videos. Do not forget to like and share our videos and subscribe to our YouTube channel No1 Doctor. With my best wishes. Dr. A. Ahmed.